Hi everyone, welcome to our second episode of our listener webinar for COVID-19. My name is TJ, I'm one of the chest registrars.
I'm Joe, I'm also one of the chest registrars here.
So today we've got a couple of episodes for you, but this first one is actually just going to be focusing on some of the updates that we've had from the last week, some of the new protocols and just some of the information that hopefully will just get around to everyone. And then the next episode, we will go through a bit of CPAP for everyone who's been asking us about things like this and how to set the machine up. So in this episode, we're going to actually focus on some of the questions that you've asked us and you sent through email. Thank you very much for those questions. We've also got to just talk through some interesting updates from what we've heard around the world, some of the most recent updates from papers, and also just to clarify a few points from episode 1.
So again, thanks to everyone who left comments from the last episode. Today we're recording on the 9th of April. So again, hopefully this is up to date to now, but things are changing quickly. We are also recording the next episode specifically on CPAP, which will go through some theory and then a practical demo. As again, we've had a lot of questions about this. And then in the pipeline, we've got a couple of other episodes coming up. We're working with Oscar and Alex from the renal team, talking about COVID in the renal cohort and AKI, and also an episode on palliative care. Just a quick correction from episode 1. Dr. Michael Chilvers is medical director and Suresh Mathapakanan is the divisional chair for medicine.
So on our last episode, we went through our RAG scoring, which hopefully more of you are now familiar with in terms of how we are risk assessing our patients and how we actually are cohorting them in the hospital. So to make things even more simpler, we'll just go through simply what the RAG score, what you need to really know about it. Green is not COVID. These are the patients that we do not think have any symptoms or features of COVID and therefore don't need a swab and don't need to be treated as COVID. Suspected cases, well, there's quite a few of those at the moment. These are the patients that might have the very mild symptoms, but we just think they could possibly have it. We're not completely convinced, but we are swabbing them if they are coming as an inpatient, and we will base our sort of assessments on that swab result and again how their symptoms are. The red cohort of patients this is probably COVID. So these are the ones that we're assessing at the front door who are coming in as an inpatient, and we think that actually based on their x-ray, based on their symptoms, based on their all their features, we think, yeah, this is likely to be COVID. And of course our black this is confirmed COVID, so they have a positive swab result. Just to say that any of these patients could be discharged. Each patient, like any other patient, just needs an assessment to say how well they're doing and whether they need to come into hospital. We have had a number of patients turn up to ED, and ED are doing a fantastic job of actually assessing each case individually and are talking to the medical team as to whether these patients do actually need to come in. These patients, so the ambers, the reds, and the confirmed cases, if they are being discharged, please do refer them to the COVID-19 clinic. Remember that C in the middle of the name. We have had an enormous amount of referrals in the last couple of weeks, and actually it's working really well. This applies to all the patients that are seen in ED as well. So if you have assessed a patient in ED who actually might be a probable COVID picture but are otherwise okay, not needing any oxygen, not needing any support from us, then you can safely discharge them and let them know that we will be calling them through our virtual clinic. So that email address again, covidc19clinic.enh-tr. As an update, as of yesterday, our virtual clinic has seen 219 patients now. So these are the patients that are, as I said, amber, red, or have been confirmed positive. And we have called these up through our ACT, the respiratory team, who have been calling these up for the last couple of weeks now. And it's been going really, really well. So as I said, it's split between the amber and the red and black groups. So far, of our amber cohort, no one yet has been readmitted. They've actually all had at least 1 or 2 phone calls post-discharge, and most of them are generally quite well and doing well in the community. From our red cohort, we have much more numbers than that, but actually only about 16 have been readmitted. But despite that, these are the ones that are actually being controlled, in the sense that when we call them up and we know that they're still a bit unwell 3 or 4 days after they've been discharged, we can bring them back in and reassess them, or reassure them and say that things are actually okay. Some of you have asked us how many admissions have we avoided. It really is difficult to say at the moment how many we've avoided. But all I can say is that, considering that the phone calls that we've been doing and the feedback we've been getting, it is significant. Most of these patients don't need to be in; they just need reassurance that things will get better, and that's what the team are doing. The ACT team are doing. They're doing a fantastic job of reassuring these patients. And this is just some of the feedback that we've been getting. So most of the patients we call, it's really quite humbling to call them, because actually they only need a couple of minutes phone call just to check on them and make sure that they're okay, that they're not forgotten. And as I said, it's been running really well. We hope to continue that.
So we're just going to run through quite a random selection of other updates that have come through to us over the last week since episode 1, covering a whole range of different aspects of COVID. So we mentioned in episode 1 that I think we all quite are familiar with now, that lymphopenia is a useful diagnostic clue that someone may have COVID. But there's also evidence that it holds prognostic value. And there's a study from Wuhan, but using the MRC lab in Cambridge, showing that patients with more severe lymphopenia, so a lower lymphocyte count, on follow-up prognostically do worse. So again, that's a useful thing to help risk stratify some of our patients. Just to highlight here, although we're not going to go into detail in PP in this episode, is that there's new guidance from Public Health England, and this has been flagged up in the Gold Command bulletin over the last couple of days. The one discrepancy that the Gold Command bulletin has flagged up between PHE and local guidance is the need for full PPE when we're doing CPR, and that's been part of the training from the resource team here. So the next point is that pathologically, it's increasingly recognised now that the underlying disease process in part is pulmonary microthrombosis, so little blood clots in the lungs. Not a full-blown PE, but in the small vasculature. So some centres in London are considering, on a fairly experimental basis, using full anticoagulation. We're not doing that here, but what is really important, as is always the case with all of our inpatients, is a really rigorous VT assessment and making sure that prophylactic alteparin is prescribed. Similarly, as we mentioned before, that adequate hydration is really important to reduce the risk of blood clots. Again, it's a fine balance, and that's something that Alex and Oscar will hopefully address in their episode next week. The balance between adequately hydrated patients to prevent AKI and thrombosis, but not overdoing things and tipping someone into worsening ARDS. The next is about smoking, something that hasn't really been flagged up that much. But again, looking at the Chinese cohorts, that we know that smoking significantly worsens outcome. The rates of smoking in China in some areas are up to about 50% in the male population. And whilst we don't see that quite so much in the UK, this is still a really important point to highlight. We have noticed over the last couple of weeks that the documentation in the medical clerking about smoking history is often missed, and I think it's really important to flag that up, because at some point during the admission, it's a really good opportunity to offer these patients counselling, nicotine replacement therapy, typically patches or inhalators, and then referral down the line to a smoking cessation clinic. So this has proven to be a really useful point to conduct that intervention. And there's guidance on all of these things on the intranet. Then arguably a patient might turn around and say, well, it's too late because they've already got coronavirus and they've come in and they smoke. I'd actually argue against that for two reasons. Partly because we know from studies that as soon as you stop smoking, there are immediate health benefits. And also, if this pandemic does have a recurrence down the line in a few months' time, for example, if patients stop smoking now, then they're likely to be protected down the line. Okay, so a few more updates. There's been a bit of confusion about the use of nebulizers. And just to be really clear on this, it's safe to use them. They are not considered to be aerosol generating procedures in the UK. And that's very clear guidance from the BTS. So if someone comes into A&E or is on the wards with bronchospasm from asthma or COPD, then please do give them nebulizers you normally would and don't hold back on those. Slightly smaller point, and one that's particularly relevant to the respiratory team here, is that a bit more surprisingly, the BTS do classify pleural procedures as aerosol generating. So that's something that we'll bear in mind when we're doing pleural taps or drains. Now, this is a really important point to emphasize, that you may well be aware from the news and from some of our neighbouring trusts that because of the pandemic at the moment, the strain on the oxygen resources in the hospital is greater than it ever has been before. So we all need to be really conscious of the oxygen that we're using for our patients. Of course, if someone's hypoxic, and a lot of our patients are, then do not hold back on giving them oxygen. However, only do that for patients who have saturations of less than 94%. There's no point in giving oxygen to someone who's saturating on air above that. Oxygen doesn't help with symptoms. It shouldn't be used for the sensation of breathlessness, only if someone's hypoxic. And what we want you to do for all of our patients on a daily basis, on a really regular basis, is try weaning them down off oxygen. Slowly titrate it down and see how they do until we can get them off oxygen. Because otherwise some patients will sit on the ward for days on end on the same level of oxygen. And I think even saving a few litres here and there will have a benefit. We know that overall the hospitals generally have a capacity of about 3,000 litres of oxygen per minute, which sounds like quite a lot, but if you consider that someone on high flow oxygen, for example, Optiflow, which we're not using too much, can use up to about 50 or 60 litres per minute, very quickly we can put a strain on the resource. Again, slightly changing tack here, but this is something that's been sent around to all of us as an urgent update from NICE in the last week, is that when we're making these difficult decisions, which again we touched upon in episode 1, about things like resuscitation and escalation, there are certain things that we should not be influenced by, and that includes learning difficulties, autism, and Down syndrome. In themselves, they should not influence these decisions. Similarly, if patients were to die, then these should not be included on the death certificate as a primary and underlying cause of death. The same guidance also flags up that the frailty scores, which we're all being directed to at the moment, should not be applied to young patients. They're only really validated and useful for the elderly population. So this was circulated around to the registrar group last week by Rowan, and I think it's a really useful resource, again, to help with those difficult conversations, particularly with patients' relatives that we're having in slightly difficult circumstances, often over the phone at the moment. So we'll leave you to pause the webinar at this point if you want to have a read through this. And it's just some really common sense, simple, compassionate ways to have these conversations.
Just to add that you can probably imagine that at the moment it's extremely difficult for some of these patients and some of these families when they have their relatives on the ward. We're actually saying to them, you can't really come in because of the risk of coronavirus, the fact that they may have been living with their relatives and they themselves are at risk. So be patient with them when they do phone the wards, asking for regular updates. Certain wards have adapted a format of doing the ward round early in the morning, going through the notes, and then having sort of a session in the mid-morning, calling families and updating them, because it is really important to let them know that things are the way things are going. But please do be patient with the relatives.
And again, you may be aware from the news, and I've certainly been asked a few times over the last week about some new serological blood tests, which are likely to be in clinical use sometime down the line. I was sent these graphics by a pathologist in London who's involved in the implementation of some of these tests. Again, if you want to have a pause at this point, it's quite an interesting slide to look through. Again, we're not using this at the moment, but it's the sort of thing that might come into place down the line. The way to interpret this is similar to the way that we're taught to look at other viruses, for example, CMV or EBV, or some of the viral hepatitis. So, for example, the blue line here represents PCR or antigen testing, which is present when just before patient becomes symptomatic, to just after up to about 28 days. And IgM rises in line with that. What's going to be really useful down the line is the IgG antibody, which develops and confers long-term immunity. So well after patients recover, it's this test which is going to suggest whether us as healthcare professionals have been exposed and have at some point in the past contracted coronavirus. And that's correlates here with these results where PCR and IgM are negative, but IgG would test positive. Again, this is more just out of interest and something to keep an eye on down the line. So a quick update on the recovery trial, again, which we mentioned in episode 1. Excitingly, now this has been given a go-ahead from the R&D department, and this is set to be rolled out properly next week. So just to go into a little bit more detail than we gave you before, the principal investigator is Dr. Mohammed Chowdhury, consultant anaesthetist and intensivist, and the deputy PI is Enrique Villar, one of our nephrologists, and the trial has been coordinated by Natalie Patterson. There's a really good webinar that is specific to the local site at Lister by Jonathan Mathers, who may be able to distribute that around to you. So it's a really broad reaching trial with inclusion criteria that basically mean that any adults with confirmed COVID-19 and without any obvious contraindications to the drugs are eligible to enter. So the patients will be recruited in 2 main areas. One will be from AMU in the medical wards, and myself, TJ, and Jay, one of the other respiratory registrars, will be helping to lead on this. And then the critical care team will be recruiting from their cohort in ITU. All these patients will be followed up at 28 days to look at things like mortality or the need for intubation as endpoints. One of the main things that we would like you to be aware of are some of the medications that are used in this trial. So some patients will be randomized to no additional treatment, so standard care. And then there are a range of other medications. So azithromycin, we think, has just been added to the trial as a new additional arm today. There's also a fairly low dose of dexamethasone, hydroxychloroquine, and then combined lopinavir and ritonavir. The last one we're having slight pharmacy issues with at the moment, so this may be on hold. So on a practical level, what we're aiming to do is all the patients who flag up on the medical take as being in the red cohort, so clinically suspected, we'd be really grateful if the patient information sheet could be distributed to these patients. So we'll leave a supply of these in the handover room. Please don't discuss the trial unless you're trained to directly with the patient. All we're looking to do is distribute the information. Then 24 hours, 48 hours later, once they test positive, then one of us from the trial team who are trained to do so will come and take formal consent from that patient. Please do not stop or amend any of these trial drugs without speaking to the research team. They should be clearly flagged up with stickers in the drug charts. And if there are any problems, if there's any suspected adverse reactions to any of the medications, please speak to the research nurses ASAP on extension 4806. If there's any other questions about this at all, do come and speak to one of us. It's quite an exciting opportunity for the hospital generally.
So just to clarify some of the ways we would like you to escalate some of these patients. So, and again, this is, most of you will already know most of this in terms of the bleep numbers as well, but we just wanted to make sure it's clear. So make sure that all your patients who've been clerked in, who are coming into the wards, have a recess escalation plan. So if they are for full escalation, make sure it's clear, that it's highlighted to the staff on the wards, to CCOTs if they need to be aware of that, just so that decisions can be made quicker and much more safely. During the daytime and to be honest, with what's going on the weekends and nights now is that medical consultants are always available now. So if you've got any unwell patient or someone that you are concerned about, that you're not sure about escalation or you're not sure really where to go with them, please flag it to the medical consultant or the registrar on the ward. We also have the bleeps for the IT registrar, which is 1394, CCOT on 1663. The ward registrars are still carrying the same bleeps as they've always done, so 0035 for the medical regis covering the tower block. The COVID medical SBR bleep, some of you are already aware of this, but this is a new bleep that came in a couple of weeks ago. Someone will be on that bleep. It may be that they might not be the person who might be able to come review your patient or be able to come to the wards to review a patient, but there'll be certainly some people as part of that team that can come help you. We also will put down the respiratory bleep, which most of you will know. When there is a respiratory registrar on the day, this will be carried by them between 9 to 5. But also the respiratory consultants are now doing 24/7 advice. So the respiratory consultants who are manning the wards will be there and also be available via switchboard. Just to say that in terms of NIV or CPAP escalations, whilst the medical registrars can assess these patients acutely and make that decision of whether we need to be starting NIV or CPAP, those decisions to actually logistically plan and where we should be starting things should be run by the respiratory team. Please don't email any patient that is actually drastically unwell or needing urgent review to the respiratory reg email address. This won't be looked at on a regular basis because we are quite stretched at the moment. So if there's any patient that you are extremely worried about on 50 meters, not working very hard with their breathing, you are concerned about them, please call any one of these numbers. And there will be someone there to be able to help you. We just put a couple of resources here for you if you want to learn more. So the London School of Hygiene and Tropical Medicine are doing a free short course online. It's available to any one of you to have a look at. It's really quite interesting. And as I said, it's free, so it's always nice to be able to do some training. And there's also some free e-learning modules as well that HEE have said that about over 400,000 people, or at least 400,000 views of the modules have taken place as of yesterday. So it's really quite useful, and again, free to look at.
So in episode 1, we highlighted some areas of support, which some of you have fed back you found quite useful. So just some additional bits to add to that. As you might be aware, all NHS staff are being offered a free subscription to Headspace at the moment, which is a mindfulness app. There are lots of other apps out there as well. Some of them, other ones are doing free subscriptions as well. So something to have a look at. This is a direct link for the Deanery, the East of England Deanery Professional Support and Wellbeing Service. There are many more rooms now available. I think 11 at the moment. I think possible capacity up to about 20 for on-call doctors, specifically who've done a long on-call shift and maybe too tired to safely travel home, particularly those who've got a long drive ahead of them. The keys for these can be signed out from the car park office underneath the multi-storey. So do make use of these facilities if you want to. Again, we mentioned last time that there is an excellent organisation offering food parcels for NHS staff. Either via this website or this QR code should be scannable on your phones, which takes you through. You can set up a quick account and order food parcels to pick up at the end of your shift, which is, again, really helpful. I'm sure most of you discovered that WH Smith are offering 20% discounts. Make sure you get that. And we've had a huge amount of donations to the trust. I think something like £125,000 recently. And all of these things should be directed to the trust's charity, including food. And we're getting a load of food deliveries from local restaurants, which is fantastic. But it just needs to be dealt with via the proper channels. You can also approach the charity if there are specific items or resources that you think would be really beneficial at the moment. You can put in requests for those, and there may be additional funding available. And the contact numbers for the charity are here, and the email address as well.
So that wraps up our second episode. The email address again, if you've got any feedback, any questions or suggestions of what you would like us to cover, if there's anything specific you want to talk us about, you would want us to talk to you about, please do get in touch. We've had quite a few emails already about certain things, so we will do our best to answer all of them and try and even get some more episodes out. So just again, a big thank you to Dr. Chong and Dr. Locke, both from the respiratory team, have been really quite integral in helping us in with these webinars and with the information. Of course, big thanks to Dr. Mark Chilvers, the medical director, and Dr. Matha Vakanan, who's the divisional chair of medicine, and of course the postgrad and comms teams for disseminating these webinars out to you. Anything to add before we finish this one off, Joe?
No, please do tune into episode 3, specifically on CPAP, as hope you'll find that useful.
Brilliant. Thanks very much, everyone.